Okay, we start in 25 minutes. Good morning, Dr. Yadav.
Good morning, good evening here.
Yeah, so I can't believe the airport was on time.
Yeah, I reached just now. The flight was delayed for half an hour, but fortunately, we did right thing.
Well,
So
you know, you can count on delay. If you count on delays, you're okay. But don't ever plan on that not being a delay. Forget it. Don't have confidence that the plane's going to leave on time.
I have requested Dr. Datta Raj from AIMS to prepare the talk 1 week before. I said in case I am delayed, then people should not be disappointed. So, he called me when I was on taxi. He said, I have followed your flight and your flight has landed. So no problem. Otherwise, he has the talk ready, and I am sure all other friends, Dr. Vijay Parihar can speak better than me, Dr. Rasim Kataria, all the panelists, and Dr. Suresh Sankla. All of them are excellent neurosurgeons and endoscopic surgeon, obviously, and master in pituitary.
Okay, let me get the
So
moderator.
absolutely, I was not worried, but I mean, as a part of duty, I thought if I reach in time, it will be better.
Okay.
Hello, Vijay.
Good evening, sir.
Good evening. सब ठीक है? All well?
Yes, sir. Yes.
Acha. Okay. I think the same plan we will, and I'll talk about this. Then the panelist comment, and then the question answers from the other people which are there in the chat box, or somebody want to directly ask, we will address that.
Okay, sir.
Okay.
Professor John, sir, Dr. Vijay Parihar is a professor at Medical College, Jabalpur, and he is expert in endoscopic surgery and hello.
Yes, Professor
Vijay
Vijay Parahar, right? Vijay.
Yeah, you have to introduce him.
Hi, Dr. Vijay. Can I meet you? How you
Hello,
doing, Dr.
hello.
Vijay? How you doing? You got the camera working okay? You got
Yes.
the camera working okay?
Vijay, I think Vijay is here, and so he is professor of neurosurgery and an excellent endoscopic surgeon, and he is one of the best exoscopic endoscopic surgeon. Exoscope. He has the vastest experience in exoscope. This is type of endoscope, and Karl Stoss, people call him for wherever there is a talk about exoscope.
Okay, Dr. Parahar, we need your camera on, please.
Parihar, I think camera on, please. Parihar.
Camera is on. I think, John, you let me in.
Oh, I'm sorry. Okay.
Okay, camera is on.
Okay, yeah, you're right. I need to let you in for you to use your camera.
Vijay Parihar, yeah.
Yeah, there you go. You're on your way in, okay? Let's see, we lack anybody else in the moderators and the panelists? Is there anyone waiting to get in?
Yeah, now his
you.
photo is also.
Welcome. Okay, BJ, how you doing?
Hello, hello.
Hello.
Yeah.
Okay, Dr. Sankla. Yeah,
Dr. Sankla,
he's a panelist, and Dr.
Yeah,
Dr.
Hi.
Dada.
Sankla sir is from Mumbai, you know the city, I mean,
course.
finance city, the capital of India, and he is an excellent endoscopic surgeon and one of the pioneer in one of the few who started pituitary surgery in India. And
He has the white hair of an expert.
Yes, thank you. Thank you, John.
You automatically become an expert in your field if you have the white hair.
That's
Yes.
fine. Thanks. Good evening, everybody.
good evening.
Good evening, sir.
Good evening. Vijay.
And we have Dr. Rasim Kataria. Dr. Rasim, please, yeah. He is professor at SMS Medical College, Jaipur. Jaipur is a pink city and one of the beautiful city in India. And there is very good active neurosurgery department, and they also do a lot of endoscopic work.
We just broadcast his conference
Yes,
yesterday,
yes.
right, Rashim?
Rasim,
Rasim?
where are you? Unmute yourself first, Rasim.
You could have stepped away, maybe.
Yeah, maybe.
No, it's good you get panelists because it really adds to the interaction. We had one yesterday from Neuroendoscopy in Latin America. We kind of could have used a couple of panelists to liven it up, and to get things moving.
hmm.
So that's what you guys
I
do
think-
well.
I think the discussion part is most important for any webinar, and we must encourage. One is the panelists should give their comments. The more, I mean, the expert panelists give their opinion after the talk, and then all the questions from the audience should be asked. Or if they don't ask questions, I have been conducting workshop as a moderator. So I used to tell that if they don't ask questions, you ask questions, panelist, or there should be more discussion.
Well, Dr. Yadav, I'm not a neurosurgeon, but I'm getting a little more confident. So if things lag, I'll ask people. I'll say, Dr. Rashim, what do you think of that? Like, kind of, I'm not as shy. Before I was afraid to do that, to talk to the neurosurgeons and ask them to comment. But now I'm not,
Okay.
because they don't bite.
So
Neurosurgeons don't bite.
what is your view? The things are moving all right, or otherwise we can, in future, we can improve upon what do you think should be done?
No, I think you guys are rather the model, because you got, prepared topic. Everyone comes and everyone, people interact during the conference. That's a big thing. And that's sometimes hard to teach. But if I told one presenter, we have to prepare. Preparation is the key. It's just like surgery, just preparing well so that you have people, because you don't want dead time, just no one saying anything. That's uncomfortable and it's not educational.
Yes.
So, but it doesn't
Yeah.
happen here, so I think we're okay.
So I think if there is nothing, then I can share my slide and see whether my video is working or not.
But you want,
As-
yeah, well, let's check it. So we got time.
Yeah.
We got a few minutes.
So is that
Okay,
okay?
there we go. There you go. Yeah.
Uh,
You got some videos you want to check?
I'll just want to see whether my video is working. These
Right.
slides are okay.
Yes, sir. It is okay.
Okay, and then the video, I think. So don't worry. I mean, I have too many slides, but only less than 1/3 I'll be showing here. Just for teaching purpose, if something else is asked, then I keep them in my presentation. So this is the only video which I have in this.
Yeah, okay. No, there's no sound in it, right?
No, yeah, there
Okay.
is no sound. I'll speak.
Oh, you kind of overview.
Yeah, I'll be telling what it shows. So the quality of video is all right.
Yeah, it's fine.
So no
Good,
problem.
good resolution. Yeah, good camera work.
Yeah, I'll be describing what is being done. So I mean, live commentary will be there. So I think that's all. So stop share.
Okay, you ready to go?
Yes.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have the distinct honor of broadcasting another episode of the Neuroendoscopy series from India with Dr. Y.R. Yadav. He's the president of the Neurological Society of India, and he's going to be talking about part 10 of his webcast. And to introduce him and to moderate the proceedings is Professor Vijay Parahar from Jabalpur. Welcome, Vijay.
Thank you, John. Good evening, everybody, and I welcome you all for this neuroendoscopy webinar part 10. And we have none other than Professor Y.R. Yadav, who is going to speak on the endoscopic approach to the pituitary tumor today evening. And as you all know, he is currently the president of the Neurological Society of India. Recently, he has been retired from the as a director and head of the Department of the Neurosurgery from Government Medical College, Jabalpur. And the center he has been established now is very well known for his neuroendoscopy work. And recently, the center has also been recognized for the WFNS for the postgraduate training. So thank you, sir, for accepting this webinar invitation. And we have also welcome our eminent panelist, Professor Suresh Sankla, sir. He's from Mumbai. He's also a very well-known endoscopic skull-based surgeon. He is the past president of Neurological Society, Neuroendoscopy Society of India. And he has been very keen to teach about the tips and tricks of the neuroendoscopy, and he has been actively participated in the various fellowships programs. We have another panelist, Professor Datta Raj from the prestigious All India Institute of Neurosurgery, and he's also been considered as one of the best endoscopic skull-based surgeon. And Professor Datta is young dynamic neurosurgeon who has been dedicated to train the resident and the young neurosurgeon from the for the neuroendoscopy training. And he has also been a very close friend to mine, and he has been very actively participated in teaching program at our institute. Welcome, Dr. Datta Raj. And another panelist is Professor Rasim Kataria from the SMS Medical College, Jaipur, who has been today only, I think he has been conducted a successful advanced course in CVJ surgery, where we have been seeing a fantastic live and cadaveric dissection. He is also a very good neuroendoscopic surgeon and very actively in the teaching among the resident and the young neurosurgeons. Welcome, Professor Rasim. And
Thank
now
you.
I request Professor Yadav sir to start his presentation.
Thank you, Professor Vijay Parihar. It is when we are presenting another series, and it's honor to talk in front of my friends and the colleague who I am intimately related. And the more important is that they are doing excellent endoscopic work. So today I'll be talking about endoscopic endonasal transsphenoid management of the pituitary tumors. You all know that endonasal transsphenoid surgery is performed through the nose and the sphenoid sinus to remove pituitary tumors or other lesions in that region. It can be performed with the endoscope or a microscope or a VTOM or all of them. So it can be done with the speculum, with the microscope, or without speculum with microscope, and it can be done with the endoscope. So I'll be talking about the endoscopic surgery, the indications and advantage, and what you should look for. Regarding the indication for surgery, it is suitable for most pituitary tumors. So almost all, not all, but almost all pituitary tumor can be done. So all functional tumor except prolactinoma, which I consider is a medical disease. All functional tumors should be operated, and endoscopy is best to do that. And whether it is functional or non-functional, and if there is compression of the optic pathway, then I think it is better to do early surgery. Most craniopharyngiomas, but we will not be discussing this topic today, except pure intraventricular lesions and those which have lateral extension are the limitations, and the other pathology including Rathke cyst and the other lesion also can be approached transnasally endoscopically. But the limitations are, so you should always have the indications and limitations. So if you have lateral extension, especially if the lesion extends beyond the neural tissue, so do not try to cross the neural tissue. You can obviously lateralize or manipulate the artery or the vessel, but if it is lateral to the neural tissue, it is not advisable to do that. And therefore, if the lesion extends superiorly and laterally to the optic nerve, or the lateral wall of the cavernous sinus where you have a lot of nerves there, then you should not try and do this transsphenoid surgery. The transcranial approach maybe the better option. And if there is a brain invasion with cerebral edema, the tumor is of firm consistency, which you can decide before surgery. The involvement and vasospasm of the arteries of circle of Willis, and if there is a kissing carotid, these are relative contraindication. But I think for a beginner, it is better to avoid these situations. Kissing carotid, encasement of the optic apparatus, superior and lateral. So superior and lateral is a problem, but if the optic canal is involved inferiorly and laterally, then you can obviously take that lesion out. If the patient general condition is poor, because most of these when surgeries are performed under general anesthesia, so poor general condition is a relative contraindication. And if there is active infection or sinusitis, so only active. But if there has been chronic infections, so if you treat the active infection and after about 7 to 10 days of treatment of active infection, if there is an emergency, then you can go in. But if there is no emergency, then in that case, it is better to hold on for 3 weeks or more. Another relative contraindication is a conchal type of the sella, because the anatomy is not seen well. But if you have neuronavigation, then you can drill that part if the sella is not well formed. And experience of the surgeon is also important. If you are not a good endoscopic surgeon, then I think it is better to do with the microscope the way you are comfortable with. But I think for all young neurosurgeon, it is a good modality, and all of us should learn this. And if the facility of neuronavigation or the Doppler are not available, especially if the pathology is complex, if the lesion is having complex anatomy, and you want to know where the distorted anatomy is lying, in that case, it is better to have navigations and other facility, and plus the experienced endoscopic surgeon. So why endonasal endoscopic compared to the other technique is that you can do transcranial, which we have been doing for many years. So the endonasal approach obviously allows the preservation of the normal pituitary gland, and there is no manipulation of the normal brain and the vessel as against transcranial approach, better visualization and the better resection rate of the large lesion. So that I'll also deal with what are the advantages of endoscopic over the microscopic technique. So, but there are limitations which I have already discussed. So the limitation of endoscopic technique becomes the indication for transcranial approach. The big advantage of endoscopic endonasal is that majority of the normal pituitary gland is lying superiorly and draped over the diaphragmatic sella, although it can be pushed on either side, on the left or the right or the anterior, posterior, and part of it is also inferiorly, which we can dissect it and spare. So, but most of the normal pituitary in most cases are lying superiorly. So if you come from transcranial approach, you injure the normal pituitary first before you deal with the tumor itself. So that becomes a major advantage of endoscopic or otherwise sphenoid approach. Regarding the workup, it is very important before you start, you should know everything about the patient. So you should have a detailed pre-operative CT scan and MRI to provide anatomical information about the bone. Bone anatomy is better seen with the CT and the soft tissue with the MRI and the paranasal sinuses. You should also be able to know whether there is any septal deviation or there is any spur which may cause some hindrance in the surgery, which also can be dealt appropriately if you know beforehand by studying the CT and MRI. The paranasal sinus anatomy also is of paramount importance because you are going through that corridor, and the sphenoid sinus because you are going transsphenoid. Therefore, the anatomy of the sphenoid sinus is very well, you should know beforehand and study the CT and MRI, whether there is a prominent sella or there is a flat sella and the amount of pneumatization. If you have a flat sella, the underlying structures are not prominent. So in these cases, to know anatomy very well, what lies behind the bone, you need possibly neuronavigation for the beginner. But if the underlying prominent sphenoid sinus is there, in that case, everything will be seen. You can see the face of carotid and various eminences, carotid, optic nerve, and the various recesses. So the prominent and flat sella or even intermediate sella, which I'll discuss later on with the pictures. And there may be dehiscent bony wall over the optic nerve. So if there is a no bone, then there is chances of optic nerve injury. So you should study that the optic canal has the bone or whether there is no bone, and also on the carotid artery. The septa may be attached to the optic nerve and the carotid artery, and if you avulse those septas, you just catch them, and in hurry, if you want to just remove it, and if they are attached on the optic nerve or the carotid artery, they will injure the optic nerve or carotid artery. So these should be known beforehand. And I say that don't avulse those septa. It is better to drill them and be safe always. There may be complex septations. Usually there are vertical septas, but there may be horizontal septas, and there may be complex septations. There may be double flooring. You may have onodicels, which I'll discuss later on, which will complicate the anatomy of the cellar floor. So all these things you should know beforehand, and whether the tumor is involving the cavernous sinus or what is the consistency of the tumor, whether it is soft or firm, because there is a difficulty in removal of the firm tumor using endoscopic technique, and this I'll discuss what are the points which denotes towards the firm tumor, and if it is present, what should be done. The position of the carotid artery, optic pathway, and the normal pituitary gland. It is paramount important to know where is the normal pituitary gland and the infundibulum, because during surgery, you have to remove only the tumor and not the normal pituitary gland. If you do that, then your patient will have hypopituitarism. So this is one example of deviated nasal septum. If you know that beforehand by axial or coronal CT scan, and then you know that on left side it is deviated, and you will have more space on the other side. In this CT scan, you know that there is a spur. There is a spur on the left side, and the same thing is seen in the endoscopic view. So this will not allow good visualization of the structure and will be hampering your endoscopic surgery. So properly deal with this. Regarding the various cella, you can have cellar type, pre-cellar type, or both these things are favorable for surgery. But if it is a conchal type, very little pneumatization, then the anatomy is not seen so well. So you need the help of neuronavigation if you want to do the endoscopic endonasal surgery. Now, these are the examples of prominent cella. You see, this is cella, and the floor of cella is very nicely projecting into the sphenoid sinus. So it's prominent cella. Then there is an intermittent, intermediate cellar, and then there is a flat cella. Hardly any projection of pituitary, cellar floor in the sphenoid sinus. So this kind of flat cella will make things difficult for beginner, because you don't see where is the optic nerve, where is the carotid protuberance, and other structures. So if you find a flat type of cella, it is important that you have navigation, especially for the beginner. But with the experience, obviously, I will tell you how to orient yourself. There are anatomies. The midline you can make out by the rostrum or the crest of the sphenoid sinus, or the clival protuberance of the artery. So by these things you can make out midline, but still for beginner, I think it is better to avoid those cases, or if you want to do it, it is better to have navigation for such cases. Now, these are some of the example. There is a dehiscent carotid canal on the left side. So left side, if you see, there is no bone. This is the carotid artery, and there is no bone over the carotid artery. So if you use by the way, although you should not use at the floor, monopolar or some other things which may injure the carotid artery. And on other side, on right side, the septum is getting attached to the carotid canal. This septum is getting attached, although there is a bone overlying this, but if you try to avulse it, you can avulse the bone, and also you can avulse the carotid artery. So make sure you know that where the septum is going to attach. In other picture, you see there is a dehiscent bone on both the carotid canal. So on right and on the left, there is no bone. There may be associated on a decel, usually, which give rise to this kind of excessive pneumatization. The bone may not be there. So in such case, there is a high risk of injuring the optic nerve also. Here another not anomaly, but it is normally seen. The septum is getting attached to the optic nerve here. So if you avulse this septum, then you may also cause injury, and the patient may become blind on that side. So studying the anatomy before surgery, and this septa is getting attached on the carotid canal on this side, and again, if you avulse that septa, you can produce the internal carotid artery injury, and this may be disaster. And the bony canal in the sphenoid sinus usually is very thin. It is less than 1 millimeter, less than 1 millimeter. So, I mean, when you try to avulse, then along with the septa, the bony canal also is getting avulsed, and your patient can have injury of carotid or the optic nerve. So don't do that. And their sphenoid sinus may have multiple septas. Usually you have 1, 2, or 3 septas, and these are vertical septas. But you can have vertical septas, you can have a horizontal septa. So you remove one septa and you find that at one place the cellar floor is deeper. At other place it is more shallow. So you should suspect that there may be a horizontal septa, there may be double flooring, and complex septations you should suspect. Because the most important, the common mistake which we do is incomplete removal of the anterior wall of the sphenoid sinus. So if you don't remove sufficient anterior wall of the sphenoid sinus, you will not be able to remove the sufficient cellar floor, and obviously the tumor also. So all septations you should be aware of, and especially horizontal septations should be removed. The important is the Onedy cell. These are nothing but the posterior ethmoid cells which extend into the sphenoid sinus, and they abut usually and surrounds the optic nerve, and at times the optic nerves are dehiscent. So, and if you don't know this, then you can incompletely expose the sphenoid sinus. And I mean, how to make out this? If you find double floor, if the cellar floor at one place is little deeper, the other is little superior, then you should suspect that and study the CT scan very well and do appropriate work. Then there may be pneumatization of the lateral recess of the sphenoid sinus. The sphenoid sinus may be pneumatized. So these are the normal sphenoid sinus where the median nerve and the maxillary nerve, that is the median canal and the foramen rotundum, are very nearby. But if there is excessive pneumatization, that pneumatization extends into the pterygoid process. In that case, there is a separation of median nerve from maxillary nerve, and this is what happens. So there has been a pneumatization here. This is the median canal. The foramen rotundum or the maxillary nerve has been displaced far away, and this is the canal which is known as lateral recess. So the line extending from median canal to the foramen rotundum and anything lateral to this is the lateral recess. And this red line shows the lateral recess, which is difficult to access if it is very well pneumatized, like in these cases. So unless you remove sufficiently bone, the posterior wall of the maxillary sinus, the medial wall of the maxillary sinus, the pterygopalatine fossa, the structures of this, then only you will be head on to the lateral recess, which I'll discuss later on also. So you should know beforehand that whether there's a lateral recess and whether this lateral recess is prominent. And especially if there's a CSF leak coming from here, from the lateral recess, which is well pneumatized, then you have to take a different approach. You have to drill the base of the pterygoid place and also the posterior wall of the maxillary sinus, the pterygopalatine fossa, and the medial wall of the maxillary sinus. This is not the topic, so I don't discuss this now. The kissing carotid, because you are coming in between the carotid, so if there's very little space available, then these are contraindication for beginner and relative contraindication even for the experienced surgeon. So the distance between the two carotid is important. These are the contraindication. You should also try to identify where is the normal gland. Usually these are draped onto the diaphragmatic sella, and these are either on the right or on the left side or anteriorly placed and posteriorly placed. The most of the normal pituitary gland in most cases are draped superiorly over the diaphragmatic sella, so that you should be able to identify, because the normal gland is more vascular compared to pituitary tumor. And also identify the optic chiasma, its position, whether the tumor is pressing onto the optic chiasm or not. And so significant part of the normal gland is on the undersurface of the diaphragm, and therefore going trans-sphenoid is an advantage, because you don't touch the normal majority of the normal gland which is there draped on to the diaphragm cell as compared to when you come transcranial. So chances of producing new endocrine deficit by transcranial approach are more compared to transnasal approaches. I'll not go into the cavernous sinus invasion, but you should know the various grades from 0 to grade 4, where there's complete encasement of the cavernous carotid, and that affects your surgery. Now, the word about whether the lesion is extradural pituitary tumor or it has some component of subarachnoid or subdural tumor. Because if it becomes subdural tumor or subarachnoid extension, then surgery is little difficult and you require more experience. So normally, when you have a tumor, there is a tumor and there is some gland on the superior aspect of this tumor. So there is one layer of the tumor and one layer of dura. So there are two layers, one of the dura and another of a residual pituitary gland, which is draped onto the tumor above, and a good radiologist can tell that. And usually, even if the tumor is not in the cella itself, it may be huge supracellular extension, but if it is smooth and has two layers, that means it is an extradural tumor, with even if it is very large. But if these layers are not there with the tumor growing too much, then these becomes flattened and they become weak, and there may be when perforation through the diaphragmatic sella or through the cavernous sinus, and there can be subdural or subarachnoid spread of the tumor. In that case, the surgery becomes a little more difficult unless you come anterior to the anterior intercavernous sinus and push the tumor inside the cavity. So that becomes a completely different approach. So if there is an irregular tumor going up with this kind of what it is known as nebbing, multiple nebbing, if you find those irregularities, and if there is a smooth extension, even supracellular, smooth. With a good MRI, you find 2 layers, then that means it is an extradural tumor, and the surgery of that tumor becomes easy. But if there is subarachnoid or subdural extension, then you require little more expertise. Maybe you might have to go more anteriorly and push this tumor and enter into the subarachnoid space, push this tumor back into the cavity and remove it. So the chances of CSF leak will be more. The multiple nibbing may be there, that suggests that it is subdural or subarachnoid extension. The word about the blood supply, because it is important, there may be situation. The blood supply of the gland comes from the center. So usually either in the anterior pituitary or in the posterior pituitary, it comes in the center, and then from center it goes towards the periphery. So if you don't find tumor in microadenoma and you are doing endoscopic surgery, so you make multiple cuts on the pituitary gland. If this is a pituitary gland, don't make cuts on the pituitary gland in the middle. If you make cut in the middle, then you injure the blood supply which is going laterally to the pituitary gland, rest of the gland. So start making multiple holes, multiple incision on the gland from the lateral side. And if there is a micro adenoma or a small adenoma, it protrudes. So you make some kind of exploratory incision on the pituitary gland. You make the nick and you find that the tumor pops out from that region. And if you don't see that, then you make another one, and like that. Or if you don't find, then people talk about the hypophyseectomy, and it is better to remove the lateral part of the pituitary tumor and leave medial portion with intact blood supply. The word about fibrous tumor, I have said that if the tumor is fibrous, then the surgery may become difficult, especially if the tumor is large. So normally 90% of the tumors are soft, but 10% pituitary tumors may be fibrous and difficult to remove. So how to diagnose them? If you find that the tumor is hypo or iso-intense on T2 weighted images, then these are likely to be fibrous, and you should be prepared. You should have a good CUSA, and you should be expert in going for extracapsular dissection after decompressing the majority of the tumor. And if the tumor is homogeneously enhancing, so homogeneous enhancing tumors are more likely to be fibrous as compared to mosaic appearance. That means it is hyper intense at one place and hypo at other place. So these are soft tumors compared to uniformly enhancing pituitary tumor. And people have done MR elastography, and in which they have found if the MR elastography values are more, then these are likely to be more firmer tumor compared to when you have MR elastography value less. So if the tumor is fibrous, it is better to go extracapsular, but it is difficult when the tumor is large. So anyway, you have to decompress first and make this tumor, big tumor into small by decompression, and then go extracapsular or use CUSA, which can allow tumor to be decompressed and then go extracapsular. Regarding the procedure, surgeon stands on the right side of the patient and the first assistant on the cranial side. So this is the patient head, surgeon, assistant, first assistant, second assistant, anesthesia, and the nurses. in the way it is mentioned. The head position, neutral position for cellular lesions, but neck extension of about 10 to 15 degree if the lesion is extending more towards the anterior cranial fossa, but neck flexion of about 10 to 15 degree if it is a retrocellular or posterior extension or extension towards the clivus. Supine position with head and elevated, the head is turned on the left side and rotated towards the surgeon so that you can see both the nasal cavity. So the point is that you should be able to visualize by the naked eye both the nasal cavity. So rotate the head in such a way towards the opposite shoulder and a little ipsilateral rotation so that you see both the nostrils. And if you are using a scope holder, which I do, then it should be attached on the left side of the table. And the other option is that the assistant can also hold the scope for you. So there is always a debate, although most people agree that if somebody is holding scope for you is better, but I am used to the endoscope holder, because when I started endoscopic surgery, there was no one to hold the scope for me. But now I am more comfortable and I don't find any limitations of using scope holders when I perform endoscopic surgery. There is no problem. Two surgeon forehand technique by nostril approach has advantage. The endotracheal tubes should be on the left side because it will allow the right nostril to be approached carefully. Change the table height in such a way that the elbow of the surgeon is at the level of the nose, so that you don't have to abduct your shoulder too much, and by slight flexion of your elbow and resting your elbow on the body part, on side of your body, or on the holder will allow the person holding scope for you comfortably, or when you are holding scope for you for some time, that is the ideal position. One or two instruments should be on either side of the scope. This will allow retraction and expansion of the nasal cavity. So there is an endoscope, and one suction or other micro instrument will expand the nasal cavity, stabilize the scope on the nasal tip, and there should be gentle cranial pressure so that it increases the working space there. You should have either 12 o'clock position of the endoscope or 6 o'clock. Most of the time 12 o'clock position is enough, but there are situations when tumor is caudally placed. In that case, it is better to station it caudally at 6 o'clock. But make sure that it is near the midline. The scope should be there and near about the septum. If you keep your scope too much laterally and then angulate it, then the orientation from the midline, you can keep it, it may be required, but then don't think of the orientation, where is the midline and how far you are away from the midline. If you angle it, then there will be false impression of how much away you are there from the midline. So try to be as medial as possible, just by the side of the nasal septum for good orientation. For surgery, epinephrine solution or the other oxymetazoline also can be used for vasoconstriction. This is the septum, this is the petty with epinephrine solution, but your anesthetic should be aware and the concentration should be less, especially if the patient has a cardiac problem. This is the middle turbinate, so this will allow lateralization of the middle turbinate on one side. So spending time on vasoconstriction, so that means putting patties for sufficient duration for about 7 to 10 minutes allows good vasoconstriction of the mucosa. So it is advisable. Don't hurry in that. If you do it, then you waste more time in controlling the bleeding. So you put the patties there, and after that you remove your fat or the fascia, or during life surgery you explain the radiology, where is the septum, where is, and what are the instruments used, so that if you keep waiting, then you tend to cut short and remove patties early. So do something else and give enough time for the patties to work and cause vasoconstriction. Thorough inspection of both nasal cavity is done to know the normal anatomy, or if there is any variation. In this case, you see this is middle turbinate, the septum, the choana, the lateral wall of the nasal cavity on right side. So identify all these structures, various turbinate, choana, septum, spurs, or the ostium, and which cavity is larger. So you work in that. And regarding identification of the choana, you follow either the inferior margin of the middle turbinate, and you find that just below the tail of the middle turbinate, you find the choana, and also just below the tail of the inferior turbinate, not below, but just posterior to this is the choana, where you have these structures used taken canal and the nasopharynx. You should also know a little bit about the lateral wall. So lateral to the middle turbinate, you have the bulla ethmoid and uncinate process and various other structures which you need not to know for pituitary surgery. But for other surgeries, CS of rhinorrhea and advanced work, and if the lesion pituitary tumor is extending laterally towards the cavernous sinus and supracellular, then you might have to deal with these anatomy also. So identify the sphenoethmoidal recess, that is the space between the middle and the superior turbinate and the nasal septum, and about 1 to 1.5 centimeter above the choana, you have the ostium, sphenoid ostium. So sphenoid ostium is an important landmark. At times it is not visualized because it is some mucosa is there. Just open about 1 centimeter above the choana and you will be there in the sphenoid sinus. Don't go too much superiorly, 2 centimeter or more than that. If you go too much superiorly, then you may enter into the anterior fossa. So error on the left side. So the sphenoid sinus is here, all up to the choana. So you can open if the ostium is not there at about 1 centimeter superior to the choana, and you will be there in the sphenoid sinus. Regarding the nasoseptal flap, you should plan flap beforehand. In most cases of pituitary, you may not require, but if the lesion is very large, and if the lesion are intradural, if there is a subdural extension, in that case, you are likely to have CSF leak, or there are intradural pathology like craniopharyngioma. In that case, you should always have nasoseptal flap ready. For preservation of olfaction, you should save about 1 centimeter of the mucosa below the anterior cranial fossa, that is roof of the nasal cavity. So 1 centimeter until you find the anterior margin of the middle turbinate. So until the anterior margin of the middle turbinate, you should be about 1 centimeter below the roof of the nasal cavity, so that you spare those olfactory fibers. But once you are anterior to this, then you can extend much more superiorly right up to the roof and then come up to the mucocutaneous junction, and then inferiorly up to the floor. So traditional nasoseptal flap may be raised like this, but there are other variants apart from traditional. There can be mini flap, where you have only the posterior part of the nasal septum which is used, especially for pituitary tumor or for smaller lesions. You can make this, because otherwise also you have to discard some of the mucosa of the posterior nasal septum to make it binostril approach. But there may be larger pathology, large tumor. I'll be discussing how to decide how much flap you have to take. So if the lesion is large, then you can extend your incision into the floor of the nasal cavity. You cannot go up, but you can extend into the floor of the nasal cavity. This is superior side, the inferior side, and then your incision may come in the floor of the nasal cavity, so that the flap becomes wider and longer. There is a rescue flap. There are situations in which you are not sure whether the lesion is small, whether there will be CSF leak or no leak. In that case, you just make a superior cut. So make a superior cut and mobilize the mucosa, and you can make binostril approach, and in the end you can just replace that mucosa back. So that is known as rescue flap. And about reverse flap, I'll discuss in the next slide. Very important thing is the spinopalatine artery. So the spinopalatine artery comes at the anterior face of the sphenoid sinus. So don't injure the main trunk or various branches of the spinopalatine artery. Usually there are 2, 3, or 4 of them. Very rarely you have only one artery. So all these vessels should be spared, because the nasoseptal flap vascularity is because of this. About the rescue flap, I said that the intraoperative leak is not expected, but it may be encountered. So in rescue flap, superior cut is extended anteriorly, and then you mobilize the mucosa, and in the end you replace it back. Now, regarding the rescue flap, regarding the reverse flap, the red line shows the right side mucosa, right side of the nasal cavity. The black line shows the left side. So you have to make, you have to use this right side mucosa for the flap, traditional flap. So all this thing becomes raw. And you have to, this is the posterior side, this is anterior side. So make a cut on the posterior side, on the opposite side of the mucosa, and then deeper towards the sphenoid sinus, and like this, and rotate it back on the raw surface on the ipsilateral side, because all these mucosa you have used it for flap. So part of the mucosa which you are otherwise going to discard because of binostril approach, so it is better to use that mucosa, reverse it on the ipsilateral side, and this will avoid crusting in the post-operative period. Traditional flap versus the posterior nasoseptal flap. So rather than having a large traditional nasoseptal flap for pituitary lesions or for small cellar or even extradural supracellular lesions, because you know that chances of CSF leak will be less, so you can use the posterior nasoseptal flap, that is some compromise of traditional flap, and this has been found to be quite useful, posterior nasoseptal flap. So how to decide how long the flap should be used? You should measure the distance. What is the defect size? That means from the ostium to the posteriormost site of the lesion, and measure the distance, and then measure. So the flap should be more than this defect. It should be about 1 centimeter, minimum 1 centimeter or 1.5 centimeter more than the defect. So you can measure the distance on the nasal septum flap and then make the flap accordingly so that it covers the defect which has been created after removing the tumor. The nasal septal flap is a reliable option when patient is 14 years of age and above, but between 10 to 13 years, because the septum is not that well developed. So you have to consider the individuals very well. And in such case, you might have to extend the flap in the floor, and sometime you might have to use bilateral flaps. So one side flap is not enough because the patient is child. So you use bilateral flap and cover the defect which is required, especially if it is a craniopharyngioma. And you should be very careful about the pedicle because the whole blood supply of the nasoseptal flap dependent on the pedicle, the blood supply, the nasopalatine artery or its branches, which I have discussed. So when you are drilling at the cellar floor, the drill itself, the body of the drill or the Carrison punch or microdebriders may injure the pedicle and your flap may get necrose. The middle turbinate removal, I do it especially when the lesion is large. You go for expanded approach, but for simple pituitary cases, it may not be required. But if the tumor is large, supracellular extension, then I prefer to remove one side middle turbinate and the other side is displaced on the other side. But if sometime if there is a bulky bulla, ethmoidal is on other side, then you can partially remove the opposite side, the bulla, or just puncture the bulla so that it becomes small, and then you can lateralize the middle turbinate effectively. The sphenoid ostium is again identified, and then you can enlarge your incision inferiorly. You enlarge incision inferiorly, not superiorly. If you enlarge it superiorly, then you may enter into the anterior ciliary fossa. But if you enlarge it inferiorly, you will be going in the, you are removing the anterior wall of the sphenoid sinus. So sphenoid rostrum and the posterior vomer is removed to open the whole anterior wall of the sphenoid sinus. So good removal of the anterior wall of the sphenoid sinus is essential. So if you don't remove the anterior wall of the sphenoid sinus very well, then there is a problem. So to do that, you have to remove the posterior ethmoid air cells. See, this is the sphenoid sinus. To visualize this lateral part of the sphenoid sinus, you have to remove the posterior ethmoid air cells. So remove posterior ethmoid air cells on either side. This will also allow you to station your endoscope and will be extra space available for endoscopic surgery. So you might have to go for a little more dissection. Sorry. See this diagram, I brought it intentionally just to show that if you remove just the anterior wall of the sphenoid sinus, which is medial to whatever is seen through the nasal cavity, then you will be removing this much only. But there are situations where there is good pneumatization. So anterior and lateral wall of the sphenoid sinus, this portion, if you just come from the nasal cavity, remove this much of bone, then you may not reach the anterior and lateral part of the sphenoid sinus. So to do that, what you have to require, this is a maxillary sinus, you have to remove part of the middle wall, medial wall of the maxillary sinus and the posterior wall of the maxillary sinus. So if you remove that, then you can go end on and can visualize, although you can visualize with the angle endoscope 70 degree, but it will be very difficult to work. So it is advisable to see end on with 0 degree in most surgery, because otherwise surgery will be very difficult. So remove all these things and you will see all lateral recess and the anterior and lateral wall of the sphenoid sinus. So especially for the lateral recess, the another thing which you can imagine from this diagram, that just by coming from the nasal cavity, you cannot go so much far laterally in the lateral recess of the sphenoid sinus. So this is the pterygopalatine fossa. So you have to remove the medial part of the maxillary sinus, the posterior part of the maxillary sinus, and then pterygopalatine fossa. Its content has to be cauterized and retracted, and then only you will be able to reach the lateral recess of the sphenoid sinus, which is well pneumatized. So when you remove the anterior wall of the sphenoid sinus, you will see the good anatomy. And the protuberances, there will be protuberance for the optic nerve. So this is optic nerve protuberance. There is a protuberance of the carotid artery. So that is carotid artery protuberance, and usually it is C-shape. So anteriorly it is more curved anteriorly. So this is there is more chance of injuring the carotid artery either more anteriorly or more posteriorly here, because it is C-shape. So it comes more medially, posteriorly and anteriorly, where you should be more careful. Here you can see that the carotid protuberance C-shape. So drill these bone overlying the carotid rather than use the Carrison punch. If you use Carrison punch, you can catch also the carotid artery and produce carotid artery injury. So this is lateral OCR, medial OCR, which is entry point. It's a key burr sort of thing, which allows you to enter into anterior cranial fossa. This is the middle anterior clinoid process, middle clinoid process. So drill it with the axial drilling. Anything between these two protuberances, that is optic protuberance and the carotid, are the carotid optic recess. And the one which is lateral carotid recess, lateral optic carotid recess, which is anterior cranial fossa, which is anterior clinoid process, and the medial OCR is the middle clinoid process. This is sellar prominence. This is clival recess. So all these structures are well seen when it is well pneumatized and a prominent sella. But if it is a flat sella, then you don't see all these things so well. So I have discussed that it is anticlinoid, clinoid. The lateral OCR corresponds to anterior clinoid process intracranially, and this is for the middle clinoid process. And after removal of bone and dura, you see the structures pituitary, the carotid artery. You can see that it is more closer to you when either it is posteriorly or anteriorly. So chances of injury to the carotid artery are more when you are working on the bone here and on the bone here near the clival carotid, the junction of clival carotid and the cavernous carotid. The word about, I've been asking so many neurosurgeons in every conference that how to introduce instrument on the other nostrils. If your endoscope is there on the right side of the nasal cavity and you want to introduce suction on the left side, because that is a blind area if you are using the telescope holder. So how to introduce the suction or any other instrument? So you should always be parallel to the endoscope shaft. So parallel to the shaft, if you become more cranial or caudally, then you will be striking at the mucosa. And you should be just by the side of the nasal septum. So just off the nasal septum and just slide the instrument passively. If there is any resistance, that means don't force the instrument there. Move a little bit gently and you will go and reach beyond the septum. So because the posterior part of the septum is removed, so therefore you can have binostril approach. So if you pass instrument from other side, then you will see it towards the anterior wall of the sphenoid sinus or the sellar floor. So this is the trick how to pass the instrument, and this is the incorrect way, not parallel. If it is not parallel, then this may cause bleeding of the mucosa. And if the assistant is holding a scope for you, then with each insertion of the instrument, you remove your endoscope and introduce your endoscope under endoscopic visualization. So that is the advantage of if somebody is holding scope for you, but the assistant has to be expert endoscopic surgeon. So that is one thing. When you don't have the orientation of the sellar floor, then the constant midline markers are either the rostrum, the inferior part of the sphenoid sinus, which is shown by the white arrows. So inferiorly, this is the sphenoid sinus. So the septas are never in the midline. Almost always they are off midline, and there may be multiple septas. So the rostrum, that is inferior part of this, is always in the midline, and the sphenoid crest, that is the superior part. So inferiorly you see the rostrum, and the superiorly the sphenoid crest is always in the midline. So you should have orientation by these two structures. And third orientation is the clival carotid. So clival, you see the clival recess, and laterally there will be prominences, and these are prominences of the clival carotid. The carotid in the clival recess. So measure the distance, and midline of this will be the midline. So if you don't see any midline, if the surgery has been done in the past and you don't see these structures, then these two clival carotid, the midline of this will be the midline. And then you drill about 1 centimeter away from here on left side and right side, So you can remove 2 centimeter of the fibrous tissue or the bone in the resurgery, and you are reasonably safe. Although you should have navigation, but in a place like where I work, where there was no navigation, so these anatomical landmarks allowed me to do the resurgery without navigation. So this is the view after you have done the posterior thrombectomy, because you need additional space to station your endoscope. These are the optic protuberance, the carotid protuberance, lateral OCR, medial OCR has been removed. So this is the bone. 4 blue lines, anterior intercavernous sinus, the lateral cavernous sinus, and the posterior intercavernous sinus. So this is the amount of bone removal which is required. And if the patient has a supracellular extension, then I'll be discussing why you need to remove the bone in between 2 optic prominences are tuberculum celli. So that tuberculum celli also need to be removed, and sometimes you need to remove the planum also, and you can extend it more laterally because there's nothing important structures. So inverted extension laterally, both planum you can remove like that if the lesion is extending more supracellular. The dural opening, devascularize the dura, but some experts say that don't do that, just open the dura because you will find space better. But I found that there is more bleeding when you don't cauterize the channels. Venous lakes are very prominent at times, and there is bleeding. So if you come across those things, then you devascularize this by bipolar, and then you open the dura either in a T shape. So just one horizontal cut in the middle of this, and then either 1 or 2 cuts on either side, and leave behind the dura in the superior part. If you make a cut there, then there will be early descent of the arachnoid, and you may not be able to take out the whole tumor. So once you open the dura, then there is thin layer of a normal pituitary also inferiorly. I have been talking that majority of the pituitary is there superiorly draped onto the diaphragm, but there is thin layer of pituitary also inferiorly. So make a small cut and try to find a cleavage between the tumor. You have a pseudocapsule. So there is a pseudocapsule is again nothing but a normal pituitary which is compressed. So there will be tumor and a normal pituitary, the pseudocapsule, and then again the normal pituitary gland. So find cleavage between pituitary gland and the pseudocapsule and separate that normal gland. It helps in preserving the hormonal functions during surgery. At times you might require pituitary transposition, but in most cases when the tumor is extending more posteriorly, the tumor itself creates space and you don't require any transposition. But if there are situations, then you go for ipsilateral dissection of the pituitary gland. Don't go for bilateral dissection and then inferior dissection and try to push the pituitary gland more anteriorly. In that case, you will devascularize the pituitary gland and there will be hypopituitarism. So you can open the one side outer layer of the dura, that is periosteal layer, and leave behind the meningeal layer and go in between this. You will find the various ligaments which are attaching from the endosteal, from meningeal layer to the pituitary gland. So remove those ligaments and you have to cut the inferior hypophyseal artery on one side. But if you go on other side and also inferiorly, then you cut the venous drainage and also the bilateral blood supply. So 100% you will have panhypopituitarism. So it is not required unilateral dissection and mobilization of the gland is enough, and you will be able to do most surgery. Regarding the tumor removal, the first you should remove from posterior side, and then from the lateral side, and then in the last anterior side. If you remove anterior side of the tumor, then there will be premature descent of the arachnoid, and you will not be able to do surgery. And when you have removed the tumor, then there is a full inversion of the diaphragm into the enlarged sella. If the complete tumor removal has been done, the bleeding also stops. But if there is no uniform descent, there are multiple loculations there. There may be some descent, but there are some crevices. So if there's multiple loculations, that means some residual tumor is there. So open the neck of those loculations, and when you open the neck by 2 micro instruments, the residual tumor comes out. And you should be able to differentiate normal pituitary from abnormal by the color, and these are more firm, it's pinkish, and there are longitudinal vessels, and these are firm lesions. Normally, just by simple gentle suction, these do not come in the suction. But if you are rough, obviously, then you can aspirate it. This is a small video of the lesion. You know, this is cellular, supracellular. The normal pituitary is above, which is hyper intense, and this is after surgery, the complete excision of the lesion. So this is the middle septum, middle turbinate removal, inferiorly the blood supply, and then the superiorly towards the anterior fossa attachment, and this is the nasoseptal flap, the superior cut, inferior cut, and the anterior cut, and then elevating the flap, going right up to the anterior wall, the superior cut extended, and now you see the anterior face of the sphenoid sinus, the bone, the posterior in the nasal septum, posterior part of the nasal septum removed, and then you have binostril approach. So owl-eye appearance, the two ostiums, the rostrum, and then this bone, the wide opening of the anterior wall of the sphenoid septum, the anterior wall of the sphenoid should be done. So this is the clival carotid, tuberculum celli drilling done, and the floor of the sella, cauterization of the dura just to reduce the bleeding from the venous leaks, which at times are more, and then extension of this cut by scissor laterally towards the cavernous sinus, make a T-shaped incision inferiorly, and then you remove tumor from the inferior part. I have been telling that remove from the inferior part and then from the lateral part on either side, left side and the right side, and then in the end, the anterior part. If you do it reverse way, Then the arachnoid, which is protruding now after the full tumor removal, will protrude in the beginning of your surgery, and the surgery will become difficult. So now it was the full. This is a full uniform descent of the arachnoid in the cavity. The hemostasis is performed. The fat is put in, especially in the large tumor. I put fat. This prevents the prolapse of the chiasma and visual deterioration. And then you put in flap and the tissue glue. Sorry. So extracapsular excision versus intracapsular. The capsule is a pseudocapsule. It's a normal gland. So extracapsular excision is required when it is non-invasive. If you have a very large lesion, then it is difficult to do extracapsular dissection, and this is indicated when there is a functional tumor. So the amount functional microadenoma, you go all around and you take out 100%, the hormonal remission is better. And if you have fibrous tumor, then it is better to go around the lesion after maybe little bit of decompression. But there is a more risk of endocrine deficiencies if you are not very careful. So you have to preserve the normal surrounding pituitary gland. There are more chances of endocrine deficiency when you try extracapsular excision. Regarding intracapsular excision, that means you decompress when the lesion is very large, you decompress it from inside, and it is good for large, invasive, and non-functional tumor. And if the patient is having associated hypopituitary, I have already discussed that if you go for extracapsular, there are more chances of producing endocrine deficiencies unless you are very careful and very expert. So by and large, the chances of producing endocrine deficiencies are more. So if there's already deficiency, in that case, you must avoid extracapsular surgery and go for intracapsular. When you have CSF leak, you can use overlay or underlay or combined or obliteration technique to repair that. And this overlay and underlay are in relation with the bone. Normally, we think underlay, overlay are in relation to the dura, but this is in relation to the bone. So underlay means that you are in between the bone and the dura. So the bone is placed, above the dura. But you can also have subdural or intradural placement of the graft, especially in the multi-layer closure when you have craniopharyngioma. Regarding the age, the piriform apparatus, that is anterior nasal opening, is small in children. Sphenoid sinus pneumatization starts at 3 years and it completes at 10 years. So the sphenoid sinus may be small in patient less than 10 years. So, and also the septum, the nasal septum is less developed below 10 years. So less than 10 years, both septum and the sphenoid sinus may be small, but the intercarotid distance do not differ as far as the age is concerned. Now, the word about how much bone should be removed, especially if you have a large supracellular extension, we tend to just remove the cella when there's a large supracellular extension. So you need to remove the tuberculum celli, you need to remove the plenum to remove this part, especially if it is firm. Because by just removing this part, this bone this tumor becomes very difficult to remove. But if you remove this bone and retract with the soft suction up, then you can access this part which is anteriorly and superiorly placed. So removal of the tuberculum celli and part of the plenum sphenoid is very important when you have large supracellular extension. The results of endoscopic surgery is safe and effective. If the lesion is small, then both microscopic and endoscopic techniques are good enough. So even with the microscope, you can take out the lesion effectively, tumor. But for large lesion, endoscope has the advantage because you can see better superiorly, laterally. So if you can see better, you can remove it better. So for large lesion, the endoscopic surgery is better than microscopic. It provides better hormonal control and better extent of the tumor removal. The vision also improves, but the hormonal improvements are extremely rare, whether you do endoscopic surgery or microscopic surgery. These are some of the examples. Before surgery, after surgery. Complications could be sinonasal diabetes insipidus, delayed symptomatic hyponatremia, CSF leak, epistaxis, incomplete tumor excision, hypopituitarism, visual deterioration, cranial nerve palsy, hydrocephalus, pseudoaneurysm, vasospasm, loss of olfaction, septal perforation, carotid injuries, synechia, sinusitis, crusting, and mucocele. I think I don't discuss because already it is 1.5 hours. So we'll discuss the complications later on. There are causes and there are methods to prevent the carotid injuries, which all of you should know very well. Although I have discussed in one of my talk on YouTube. So if required, I will have another talk sometime because it will take another half an hour. Incomplete excision, especially the anterior cellular floor is less, drilled, and the plenum and the dorsum celli has not been drilled well. I have discussed the cause of injury, maybe Carrison punch or drilling the carotid. Visual deterioration also, there are causes and you can prevent them. CSF leak, likewise, but I'm sorry, I think I have to sum it up. There may be symptomatic hyponatremia. You have to differentiate between salt wasting syndrome and SIADH. Diabetes insipidus is another complications. Hydrocephalus and sinonasal complications worsen or new pituitary dysfunctions are another reasons. And epistaxis, pseudoaneurysm. To summarize, detailed preoperative CT and MRIs are important. This allows all the things which I have discussed, that what is the type of the sphenoid sinus, whether it is prominent or flat, and whether there is dehiscent wall on the optic nerve and the carotid, where is the septum attached, whether it is attaching on the optic nerve or carotid, double flooring, complex septations, cavernous invasion, the tumor, whether it is soft or firm. All these things are important. Where is the normal, where is the carotid artery, where is the optic pathways, where is the normal gland and the infundibulum. Results when it is a small lesion of microscopy or endoscopy is same, but if the lesion is large and there is a superior and lateral extension, then endoscopy is certainly better. The endoscopic provide better hormonal, I mean, um, when the rate of hormonal deficiencies are less, because you see better the normal pituitary. So therefore, the hormonal vision and the total excisions are better in the endoscopic surgery compared to microscopic surgery. The complications are almost same in the microscopy and endoscopic surgery. But these are performed for the smaller. Microscopic surgery are performed for a smaller, the intracellular lesions. Now, I think hardly anybody, if there's a large supracellular, then most of us do not do microscopic surgery. The vascular flap has reduced the CSF leak, especially when the lesions are large or if there is a intradural extensions. Thank you very much. Thanks. I think
Thank you,
I'm
sir.
sorry, exceeded. Still, the complications have not been covered. So, sometime other time we'll do. Otherwise, it might have taken another half an hour for complications.
Okay, Vijay, it's all yours.
Yes. So, I think Dr. Vijay, please invite comments from
yes,
panelists.
panelists.
Yeah.
Yes, thank you, sir, for very elaborative and very basic tips and tips about the endoscopic pituitary surgery. We have our panelist with us, and I invite Professor Sankla sir for your comments and suggestions.
Thank you, Vijay. I think this was a wonderful lecture. I have really heard this lecture several times from Professor Yadav. But I guess for a young endoscopic surgeon who is interested in doing pituitary adenoma, I think there are lots of information which Professor Yadav has tried to give during this lecture. And I don't know there is anything else I need to add. What is most important from his lecture that you must know the anatomy so well, so that you at any point, at any stage of the surgery, you are not lost. Not only lost, you know where exactly you are and what you need to do. During surgery, there are several times when you have different situations, unanticipated and unexpected visions and circumstances during surgery. If your anatomy is not clear, you really get stuck completely there, and then you end up doing something which you should not. So I think knowledge of anatomy is very good. The other part is, the technical stuff, which everybody comes to know over a period of time, and there is some learning curve with the endoscopic surgery. But I guess once you start doing it more and more, you really get used to it. But what Professor Yadav has given you some tips of how to remove the tumor, which part of the tumor should be removed, and all that. All these tips look very small and not very impressive, but believe me, if you really do good pituitary surgery, then these are the tips which will be very, very important for you to follow. And I guess more interesting would be to hear from him to avoid complication and to manage complication. Unfortunately, because of lack of time, we couldn't cover that, and we will probably do it some other time, because that is also equally important thing. So thank you very much, Professor Yadav, for giving us this lecture on this. And we'll take the questions from the audience after we really hear from the other panelists.
Thank you, sir. Thank you.
Thank you, sir. Professor Asim Kataria, your comments, please.
Sir, thank you so much for a very comprehensive talk, as always expected from you. My question to you, sir, is what are your maneuvers? How, in a large like supracellular component, how do you make the tumor fall to your approach? How you make the tumor fall towards you?
Yeah, so the most important thing is, remove the bony portion sufficiently, especially suprasellar lesions. They don't fall if it is little firm lesions. So if you remove the tuberculum celli, if you remove part of the planum sphenoid, which I told you, to have access, you have to have before surgery the line joining that. So how much bone you need to remove to remove that part of the lesion? If it is firm, at times it is soft and it falls. But there are situations when the tumor is firm and their tumor is a dumbbell shape. So in that case, you have to remove bone more, and then with one suction you push the, even if you don't open the dura there, just by pushing the suction cranially, you extend your corridor bigger and take out the tumor from anterior and superior portion. There is hardly any problem in removing tumor from posterior side and on the lateral side, except in a situation when it reaches up to, beyond the middle portion of the carotid and laterally, then obviously it requires more expertise. But superior, we usually leave tumor behind, which is suprasellar, anteriorly placed. So for that, you have to remove the planum and the tuberculum celli well.
And sir, the role of Valsalva maneuver in this?
I don't think, I don't advise this. It causes rather more harm than doing good. There may be, your arachnoid may come and bulges within your field, and a small tumor may be left, a pouch may be left there. So I don't really ask for Valsalva unless I want to see how much, whether the CSF reconstruction, when there's a leak, then I request for the Valsalva, not for the tumor removal. It is rather harmful. Some of the tumor you may leave behind, the arachnoid may bulge. I think I was thinking of something which I forgot to tell. Yes, if you have subarachnoid extension, so in that case you have to go anterior to, anterior to the diaphragmatic celli and open the dura there. So go suprasellar, push the tumor back into the cavity and do the dissection. So in that case, you have to go for good CSF closure. So if it is a firm tumor, if there is a subarachnoid extension, and then you have to open anterior to the diaphragmatic celli and try to push that tumor from the subarachnoid space into the cavity which you have created. And in that case, the repair of the defect becomes very vital. Otherwise, CSF leak will occur.
Thank you, sir.
Professor Yadav, just 1 minute. Yeah. How far laterally do you go safely? If the tumor is involving the cavernous sinus, the medial cavernous sinus, how far laterally you go?
I bear the carotid artery, sir. I don't go beyond that, because there are people who talk about that you can go lateral to the carotid artery. Obviously, yes, but then you can take out the tumor lateral to that, but then you produce more harm by producing the cranial nerve palsies. So I think you have to see the long-term results of the patient, not that you remove tumor. So leftover tumor can be very well tackled by radiosurgery,
Yes.
rather than very aggressive removal of the lateral parts. but I bear the carotid artery fully so that I can retract it medially, and the portion which is going inside the cavernous sinus, it can be removed. Medial portion of the cavernous sinus.
All right,
Sir.
thank you.
Yes, Professor Datta Raj, would you like to say anything? You
I
have-
think Dr. Vasankla sir and Rashim sir has very nicely summed up the things. And sir, any idea about, like, your opinion about tumor which has large supracellular extension and approaching it from transcranial and transsphenoidal way?
Yeah, so the contraindication for nasal surgery for pituitary adenoma is almost nil. Those cases which are so big, even if you go for transcranial approach, it's very difficult to take out those massive pituitary adenoma in one single sitting. So most of the pituitary tumor can be removed transnasally, but if the extension is more lateral to the neurovascular bundle, if there is associated cerebral edema and the cap is not there, the cap, and if there is a vascular encasement all around, then dissection of that particular nerve becomes very difficult because there is a narrow corridor. So it is better to have good control. So vascular encasement, the best tumor going lateral and superior to the optic nerve, superior and lateral. That is contraindication. And obviously kissing carotid and other things. If there is active infection, then you treat the infection first. So these are some of the limitations. And if the sella is not so well pneumatized, you have concal sella, then you have to drill it too much and use the navigation too much. So it is better to take the other approach, transcranial, which is also quite effective. So, proper judgment about proper approach. In other words, for pituitary tumors, 95% or even more than that can be removed transcranially.
Transsphenoidal.
Endoscopic transsphenoid. Very few indication for transcranial.
Thank you very much, sir. It was a very nice presentation.
There are some tumors, large tumors. Vijay, sorry, just last question.
Sir.
Yeah, so where you know that you might have to go transcranially also to remove those tumors, the residual part, okay. But largely the tumor is cellular based, the cella is enlarged, some part of the tumor is projecting into the sphenoid sinus and everything looks fine. So in that case, which approach you take first, transsphenoidal or transcranial?
Yeah, sir, I take transsphenoid because I know that most of, the 90% or more than 90% can be removed through transsphenoid approach. And if it is a non-functional pituitary tumor, because today we are talking about pituitary tumor, leaving a small portion of the tumor is better than producing multiple cranial nerve palsies and other CSF leak and meningitis. So I think for non-functioning tumor, you can leave little bit of tumor and observe it, and if it or people have described, I'm aware that there may be combined approach, transsphenoid plus transcranial, or one after the another. So it is an individual choice, patient age and everything looked into account, sir.
Thank you.
Sir.
Thank you very much.
Sir.
Vijay.
Thank you all the panelists. And now I'll take the questions from the audience. There is one question from Dr. T. Narasimha Rao. What about the diffusion weighted image predicting the consistency of the tumor? Dr. Rao is from Hyderabad, Omega Hospital.
So diffusion weighted, I'm sorry, I am not aware, but I think the T2 weighted hypointense and this thing or MR elastography, it is only in the literature which I read, not from no personal experience. So if you have any idea, please tell or write in this. I have no idea about diffusion weighted. Any of the panelists, diffusion weighted MRI and the consistency?
Nothing particularly. What about the Taraj? Do you have any idea about the diffusion weighted for pituitary tumors?
So not it's just about the water content, sir. More water content. It is like shows more restriction, less restriction. That's kind of the concept, basic concept, but not routinely utilized in the daily practice.
But I think T2 weighted, as Professor Yadav said, is a great sequence, and by that you can really make out so many characteristics of the pituitary adenoma. Thank you. Any other question?
I have seen only this question. John, have you seen any other question in question answer box?
That's it so far in the chat.
Okay, then we conclude.
Can I ask?
Yeah,
Yeah.
Dr. Asim.
Yeah, Yadav sir,
Yes.
what are the mostly the causes which leads to hematoma formation after surgery, and how can the chances of hematoma formation be minimized?
Yes. So the most important cause of hematoma formation is incomplete tumor excision. If you remove, and that is what one should not do, incomplete tumor excision in pituitary tumors lead to the hemorrhage, and which may be very disastrous. This is one thing, and the other, possibly you have injured some of the vessel and imperfect hemostasis before starting. So even in those cases, it is because of the incomplete tumor excision. Once you remove tumor completely, the bleeding stops of its own just by irrigation. Or some injury to the cavernous sign. So simple packing or putting in Surgicel for some time, the bleeding stops or flow seal. So improper hemostasis or incomplete excision of the tumor are the cause for hematoma
Thank you, sir.
formation.
Dr. Harshat Parekh was there. I think he is not there. He was a regular.
He was
Indeed.
there.
Yes,
was,
sir. Yeah, sir.
He always commented at the end. I didn't see him right now in
Today,
this.
I think we are late.
He was there in the initial part of the webinar. I think he must have left by now.
Yeah. So I think we should conclude, sir.
Yes, please.
Yeah, okay. Well, thank you guys. Dr. Yadav, you guys may forget what it's like to be a young neurosurgeon and just listen to neurosurgeons talking in the surgery lounge or whatever, just to listen to you guys. And this is what it's like. I'm sure the young neurosurgeons appreciate it. And I hope we brought it to a lot across the internet. And we look forward to seeing you next week for number 11. What is the topic next week, Dr. Yadav?
I think spinal tumor or something. I think spine tumor. I'll just look around.
Yeah, let me punch it up too.
That you will-
We're not gonna get any prizes for production here. But
Yeah,
yeah,
yeah.
endoscopic,
I think it is the endoscopic posterior approach for multi-level compressive cervical compressive myelopathy.
very good. Okay, thanks everyone for coming, and we'll see
Sure.
you next week.
Bye bye. Thank you.
Thank you.